world that puts a lot of emphasis on body size and shape, and often leads us to link self-worth to body size and shape. So if we let that go, if we don't challenge that, if we don't help people with that, then the worry is your self-worth improves as your weight drops, and then as soon as your weight comes up, your self-worth goes down. So we need to break that link.
This week's episode of the Barry Chronicles is brought to you by Cost Price Supplements.
Hey everyone, I want to welcome Dr. Alex back to the Barry Chronicles. I've got my surgery coming up in less than 2 weeks with Dr. Alex, so that's really exciting. I thought maybe we could have a chat about gastric sleeves and the reason that people may need revision surgery. Been getting a lot of questions from people. If I'm going to have a revision, should I just choose bypass to start with? Alex, thank you for joining us, and welcome to the Barry Chronicles.
Yeah, pleasure to be here as always. I don't think we chat often enough, you and I think that's maybe because I keep standing you up like a jerk because other things get in the way. So
you're a busy man.
It's all on me, mate. Yeah, great to be here. I think this conversation really came out of you and I talking about expectations, and I think my discussion with you that a lot of people that I see when they're thinking about revision, whether or not the revision is a good idea or not, are often carrying unrealistic expectations. And it goes both ways. They're expecting that their surgery should have done something that probably statistically it was unlikely to do. And then on the flip side, some of them are putting up with negative symptoms that their surgery was not supposed to cause. And so I think, that led to this idea of well, maybe we should talk about what, particularly for sleeve, because it is the most common metabolic bariatric surgery out there at the moment.
Yeah.
What realistic, sensible expectations look like. So I think that's where we got to.
I mean, I had my sleeve 12 years ago. I guess if I had have known some of the issues that I would have had after my sleeve, then I would have gone straight to bypass. But hindsight's always perfect. Do you think we often, or some people see that there's so many more complications with a particular procedure because it might just be what they're researching, and it's sort of what you're looking up at the time? It doesn't mean that there aren't complications with other procedures.
Yeah, so I think definitely, and there's a little bit of human nature thrown in there. So what's newsworthy is always the extremes. So the things that catch our eye are people who are having a really positive outcome from something, often beyond, they're an outlier, what we would call a positive outlier. So they're doing better than we would ever expect. And we're seeing this now with the medications. We see people go, look at this wonderful thing that happened to me. And that is wonderful for that individual with their genetics and in their life, but it doesn't necessarily translate. But we naturally kind of get drawn to that really good news story, and equally the flip side. And so to put it into context, we should probably remember that 95% of people that have a laparoscopic sleeve gastrectomy, that is the only operation they have. They don't go on to have any revision. They live a very healthy life. We have lots of evidence to show that quality of life improves. You and I have both looked at the data showing that these people live longer lives with less disability and less disease. And so the majority of people, it would be easy for me to get down because, yes, I do meet a lot of people that have a sleeve gastrectomy and have problems with that because there's lots of sleeves hanging around in Australia. But it's always worth, this is not the majority of people. This is a minority of people that end up with these issues. Now, that is still very important. They deserve to have these issues managed well, and they deserve to have access to whatever investigations and treatment they need to rectify those issues. But the majority of people, honestly, statistically, that's all they need. They carry on. They're great. They're happy. And that's not really the sort of news that we hear, because I'm not gonna put an Instagram post, hey, my life's good and normal.
Yeah. Yep.
That's not interesting to anyone,
Yeah.
So I think that's worth the context. The other thing I'd say is that in every area of medicine, we have this saying, there's no side effects, just effects. So if something is effective, it is going to have an impact on the human body, and that will have positive outcomes and negative outcomes. And so then there are complications, then there are issues, then there are things that go wrong. But even when things go right, there is an effect on the human body that will differ from person to person, and that can have some downsides for people as well. So I think, if we look at sleeve gastrectomy, I think first it's worth knowing what this procedure does, what it's designed to do. There's a lot of talk about these ideas of restriction and malabsorption, and they're pretty outdated ideas, and they're pretty outdated terminology, mainly because when I talk about restriction and malabsorption to an upper GI surgeon, we have a fair idea of what we're talking about when I talk about these things. But I don't think we've explained that well to the populace at large. And so the words themselves are a bit misleading. And honestly, we don't have a good definition for them. So the restriction thing, if you like, I would describe that as restriction being an issue with hold up and slow passage of food through the esophagus and upper stomach. That's what I would call restriction.
Yeah.
Malabsorption would be food not being absorbed sufficiently to avoid things like diarrhea or gross protein and other deficiencies. The reasons these came up, I think, historically is surgeons, honestly, we're a pretty pessimistic bunch. And so when we looked at all these people that had bariatric surgery, the people that got the most weight loss often had issues with restriction and malabsorption. And so it was sort of the assumption that, this is why the weight loss is happening. And what was missed, I think, in that conversation until quite a lot later was the fact that actually most people had neither of those things. They didn't really have any measurable evidence of malabsorption. They didn't really have any measurable evidence of restriction or symptoms thereof, yet they were still doing really well. They still had really good amounts of weight loss, but also really good health improvements in other areas.
Yep.
That led then to some really cool articles by endocrinologists where they looked at, well, here's all the things that sleeve gastrectomy does. Here's all the things that Roux-en-Y gastric bypass does. And yes, in some people it causes restriction, but then there's all these other things. And that's when the story of the hormones started coming out. I started to realize, okay, it's actually changing the body's hormonal response to food, the body's neural response to food. And suddenly we realized, there's a whole lot going on. And yes, restriction may add a little bit of weight loss. And yes, malabsorption may add a little bit of weight loss, but often with a few negative effects. But then there's all this other stuff, really good stuff going on. And the negative effects of that are really minimal. And in fact, so minimal that now you can take some of these hormones, make a drug that mimics their action very powerfully, and then sell that medication. And of course, there's a whole group of medications that are mimicking and amplifying the effects of bariatric surgery or metabolic surgery. Yep. And that's what we call it, metabolic instead of bariatric surgery now, because bariatric means to do with weight, whereas metabolic means to do with your metabolism. And from a purely medical point of view, the weight's not where the action's at. You and I have spoken about that from ages ago that, as a medical doctor, I'm not really supposed to concentrate on your weight until I've concentrated on disease, function, quality of life, and risk of you dying. Then I can worry about your weight because it's less important, than all the other things. So that I think is worth noting. And so I guess sleeve gastrectomy now is the way I explain it to people, medical students or anyone, is designed to increase the body's sensitivity to small volumes of food. So it creates a narrower shaped stomach that is less stretchy. And so not to create that uncomfortable fullness feeling. I'm not talking about that. That's a separate issue that we can talk about. But so that what we notice is with smaller amounts of food, the nerves in the stomach that detect stretch start firing. And so the body is more sensitive to small amounts of food than it would be otherwise. And the second is it's designed so that food very quickly exits the stomach. So as soon as food sort of comes down, and if we do swallow tests for people, we'll notice this, that within a swallow or two, food is already out into the small bowel. Almost before the second swallow hits down, we've got a little bit of nutrient hitting that small bowel and setting off a whole lot of hormones. And so those are the mechanisms of sleeve gastrectomy, if you like. They're the ways that sleeve work that really excite me, because those ones don't tend to come with any negative symptoms. The stomach's just a bit more sensitive to a small amount of food. All this hormonal stuff is happening, good things are happening, and you don't have to feel uncomfortable. So those are the things about sleeve that I'm really excited about and I want. Now, also, you can do things with the sleeve gastrectomy. You can shape it in certain ways that I can make people really uncomfortable, and they might even lose more weight, but at a cost that I don't really want to pay. So when I'm shaping a sleeve, that's what I'm looking for. And I think that's the key. And I use that word shaping a sleeve gastrectomy. I think sleeve gastrectomy is a terrible word because gastrectomy means stomach removal. And that's not where the action is at. What's left behind is much more important than what we we remove. You'll hear, hear people asking, do you take out 50% or 60% or 70%? So if you're wondering about that, you're missing the point. It's the shape that's left behind. That 60, 50, 70, 80, 90%, that's going to the pathologist. That's going to be in a lab, and then it's going to be in a biochemical waste disposal bin. That's not doing you any good. The sleeve that's left behind does. So that's the things. So those are the things that we're looking for. That leads us to think about, well, what should we expect after sleep? And so that's what we should expect. We should expect that the stomach remains sensitive to smaller amounts of food, and food gets out more quickly. And that creates this issue of often people in the early instances do feel restriction. So when people wake up after a sleep, it is definitely there, that restriction. So in the first week or two, it's restricted. Every swallow needs to be done with careful and precision. And some people feel like, okay, every swallow is like a golf ball. That goes away very quickly, though. Most people will find within 6 weeks, certainly within 3 months, that's all gone. You can eat real food, and you should eat real food, and we want you to eat real food. So the restriction's gone, but the weight keeps falling. So that level of restriction is not necessary. In fact, I would think unhelpful, because it's going to stop you from eating real food and protein and fibrous vegetables and all the things I want you to eat, because they're independently good for your health. So that should fade away. Early restriction should go away, and it should kind of stay away. And in fact, if it comes back, if in the long term you're like, oh my gosh, I feel like I've had my sleeve again, that's an important symptom that you deserve workup for. And it's not something we should be chasing. And often people find that they eat into that naturally. They sort of think that they need to be restricted. So often we'll see hurried eating or bigger meal volumes to sort of lean into that uncomfortable feeling. Because it's almost, without the right sort of education from a dietitian beforehand, you can easily be led into the idea that that's a necessary symptom to get the benefits from sleep, which it isn't. The other thing that we need to be clear on is that once people reach plateau, it is normal for a bit of all of this to ease off. And so I think often people think, oh my gosh, my hunger's coming back, my sleep has stopped working. No, you're allowed to have a bit of hunger come back. That's okay. My meal volume has gone up. That's okay. And really, again, it's a human nature thing, is we keep comparing to what happened yesterday instead of when we started our journey. And people are telling me, oh my gosh, I can eat so much now. You said, well, just have a think about pre-sleep days, what an average meal looked like when you ate enough to avoid snacking before the next meal. How much food did you need for that? And what about now? And oftentimes, actually, no, I still have a much smaller meal volume than I had before. But it's easy to forget that, because 3 months ago I was eating half a cup and now I'm eating a cup. So I'm eating twice as much, but actually you're still eating a quarter of what you would have before the sleep. Yeah. And able to avoid snacking with that.
Yeah. I've had people even just recently sort of say, I'm 6 months out and I'm still only having 3 teaspoons of food at a meal. And then other people will sort of, I can eat half a cup or a whole cup of food. Have I stretched my sleeve?
Yeah.
And it's like, well, from my experience, it's very hard to actually stretch the sleeve, and especially in 6 months. I really wouldn't imagine that many people would successfully do that. It's just different anatomy. I had crazy restriction after my surgery, and I ended up needing a dilation done to stretch the esophagus a bit so that I could actually eat food. And I found after that, suddenly I can eat chicken again. It's not making me vomit every time I try and eat it. How much should someone be looking at having at sort of the 3 month mark, the 6 months?
Yeah. The first thing I look for is you want to know, is someone texture limited or volume limited? So by 3 months, you should not be texture limited. And what I mean by that is the type of food shouldn't be a blockage. So yes, you will tolerate more if you drink fluids than if you have solids. But by 3 months, there should not be a single texture of food that you could eat before that you can't eat now.
Right.
That's what normal looks like. So the first thing is you should not be texture limited. And that's part of that restriction thing. Restriction, I think, comes with that texture limitation. People who have had a laparoscopic band will know what I'm talking about. When the band gets tight to a certain point, I can't eat bread or meat or chicken or whatever, and I have to go down to liquids, which is not really good for us. And so we shouldn't be seeing that with sleeve. In the first little while we do that, we do start with very thin things and thicken up. Honestly, though, if you want to peek behind the curtain, that's not really because we think texture is so important. It's just that we're so worried about you needing to get enough fluid and enough calories to come through and not lose too much muscle mass in the first month. And we know you're going to get more of that in if you've got a thinner diet. That's the main reason we do it. There are a lot of people that will cheat and they'll come in looking very red-faced. Oh, I had a bite of a burger. And I was like, what happened? Oh, it went down fine. I'm like, yeah, of course it did. The problem is if you're eating nothing but solids in those early phases, sometimes you just can't get enough in because it's sort of so filling. So you should not be texture limited. Now, you should still be volume limited. One of the things that I would say, though, is there is an important concept that we teach here, particularly with the dietitians I work with, the difference between satiety and satiation and fullness. And so for me, I come from sort of that, a Caucasian heritage. I call it the difference between the snack on the run and the Christmas dinner. And what we're really talking about is your minimum food amount and your maximum food amount. So your minimum food amount for me for a meal is how much can I eat now that I'll be not still starving hungry? And I can go for a sensible amount of time before needing another meal. So how much do I need to eat for breakfast so that I don't have to snack before lunchtime?
Yep.
How much do I have to eat for lunch so I don't have to snack before dinner, right? So that's what I would call the minimum amount of food. Then there's the fullness, which for me is that kind of very satisfied, but also a little bit uncomfortable feeling I have, like after Christmas lunch or a Boxing Day when I'm eating the leftovers, where I'm like, oh, I'm a bit uncomfortable. What we find over time is that in most patients that I work with, the maximum amount of food goes up to a much greater extent than your minimum amount of food. And so what we'll often do is just have, people are, I can eat this much, 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 but do you have to? Now, if you have to, you have to, and I want to know about that, and that's important. We need to look at that. But sometimes, and certainly in my upbringing, I was certainly trained to eat every morsel on my plate and go back to second. Yep. It was sort of ingrained with me, because I have a loving family, and that was, we express love through food. Yeah. So that was, I'm not saying that was a bad thing. Quite the opposite. I love when I was cooking, and I'm so glad she fed me as much as she did. But that is something that as I get older, just because I can eat that much doesn't mean I probably should eat that much. But it's always a little bit hard because you don't really know until the next meal, right? So you don't know if I've had enough breakfast until I get to lunchtime and I had to have, a coffee and a snack in between. Oh, geez, I didn't have enough breakfast. But, this is something you can play with. But that's the thing. And so after sleeve gastrectomy, if people's maximum meal amount has gone up a lot, I'm not too worried about that. Because this operation, the modern sleeve gastrectomy, was never designed to restrict your maximum food amount. It was designed to help you with your minimum food amount. That is the amount of food you can eat, not as little as possible, but sensible, to make adequate portion control work for you. Yeah. And part of the problem with obesity is adequate portion control doesn't work. Because the body is just like more. No, I want you to weigh as much as you did last year, even though that's not healthy for you. I am biologically designed to bring you up here. That's where I want you. And so that's one of the things I'd say about this food volume. It's supposed to go up, but and food volume does go up over time. Every time we've studied it, and just because your maximum food volume is going up pretty quickly doesn't mean that your sleeve has stopped working. Doesn't mean you've stretched your sleeve. All of this sort of stuff. Some people do have sleeves that stretch. And I want to be clear that some people's stomachs are stretchier than others. So just because your sleeve might be larger now and might have stretched doesn't mean it's because you've done something wrong. You just often have different collagen. And the final thing to say about that is a lot of people have larger sleeves and really good outcomes from sleeve. And a lot of people have weight regain, sleeves not working for their diabetes the way we would want, all these sorts of things. We're still very narrow and normal sleeve shapes. So I guess, insufficient treatment effect from sleeve gastrectomy and a larger stomach are not always connected. You can have a very normal looking sleeve and it just didn't work for you. And you can have a very baggy, saggy looking sleeve and you're doing great. And so I think we put often a lot of weight on that. And oftentimes people really get worried because, something happens. They had a big celebration and they just ate and they were in and it was social and all these sorts of things. And they had a big meal and they think, oh my gosh, I ate so much. My sleeve must have stretched. You're like, no, you're probably just normal. And that's okay. Does that make kind of sense? Does that cover that a little bit? Yeah.
Because I think that's great because I think it's just something that most of us worry about is ending up back where we were. And I think there's a real fear about that. But I think a lot of that can play into the body image as well, where, we can look at weight lost as the success point or the failure point. And so then if there's any sort of regain, oh my gosh, I failed, even though, for me, I was a perfect example, as you know, I'd lost 110 kilos, regained a little bit, and I was feeling like I'd failed and wrecked it, even though I was still 100 kilos down from my heaviest. Well, I look at that now and I think that was such stupid thinking. But I think when you're really scared of going back to that, any little change that you think shouldn't be there, it's like, oh my gosh, I've wrecked something, I've done something wrong.
And I think I would say, first of all, and I'm stealing this from someone, I think it's a UK GP, but your anxiety makes sense. It's not irrational. That worry is sensible, rational thought. Unfortunately, we live in a world that puts a lot of emphasis on body size and shape and often leads us to link self-worth to body size and shape. So if we let that go, if we don't challenge that, if we don't help people with that, then the worry is your self-worth improves as your weight drops. And then as soon as your weight comes up, your self-worth goes down. So we need to break that link. It is really important. The other thing to be very conscious of is in all areas, we readjust our expectations as we go. So before you had a sleeve, how much weight loss would you have been like, wow, this has worked, I'm happy now? Like if you can imagine back, would it have been 10 kilos, 20 kilos, 30
10 kilos, I would have been over the moon.
Yeah. And then when you got that 10 kilos, what were you thinking then?
I need
another 10. Yeah. Not want another 10. I want another 10. I want another 10, right? That is normal human behavior. Again, it makes sense. It's not irrational. But then, of course, often then too, and this is well-meaning, I'm not detracting from it, often we get a lot of love. Weight comes down, we're at or near our nadir weight. We're putting up some before and after photos on social media. We're seeing friends and family we haven't seen in ages. Man, you look freaking great. I haven't seen, you look so well. And they're trying not to talk about the weight thing, but they kind of are. And it because you're moving better, you're looking more confident, you're looking stronger, you're feeling good. So you are looking, people are happy for you and they're celebrating you. But then we have what we sometimes call the lights go out in the stadium effect, because that's not new. You see that one friend you haven't seen in 3 months and you've lost all that weight and they make a really big deal about it. But when you see them in another 3 months, another 3 months, another 3 months, that's not new anymore. They're used to that. And so they don't mention it. It doesn't mean it's any less good, but they're not mentioning it because it's not new and exciting. Plus, if you put it on a little bit more weight, then you're thinking back to the times that you weighed this much and it was a big celebration and now I'm not there anymore. And so we've reset our expectations. And so it's really important that we look back way before this and say, well, where were we when we started this journey and where are we now?
Yeah.
And it's so easy to forget about that.
Yeah.
And a lot of people that are sent to me have that failure narrative going. And I will meet people started at 150 kilos. They haven't had any surgery. They've had diet medications. They're sitting around 120, 30 kilos gone. And I get a referral saying that they have, quote unquote, failed diet and medical therapy. They've had very successful diet and medical therapy. Now that they might still have clinical goals that we can help them reach with surgery. I'm not saying that. It's fine. They're allowed to come to me and I want them to come to me, but I kind of hate that they have to come to me with that failure narrative.
Yeah.
When really that's a success narrative.
Yeah.
If you are sitting below your starting weight Between the ages of 20 and 70, your weight should be going up. If you're sitting below your starting weight and you're maintaining that for a long time, that's not normal. You're bucking the trend. You're going against biology. Good things are happening, but we can often leave that. And so the same is on the other side of surgery. We know there is a pattern for waves after sleeve gastrectomy. We know there is a sensible expectation. There is a wide range in outcomes, but we know roughly what that should look like in terms of weight loss. When we talk about the Nike tick, the rapid weight loss, the rebound a little bit, and then what we return to what we call baseline weight trajectory. That is, most of us between the ages of 20 and 70 put on weight in the real world. And it's interesting to me now that initially, when all the medication trials came out, people were super excited because when you're in a randomized control trial, your weight comes down and stays very flat. And then what are we seeing in the real world studies? Nike tick.
Okay.
Biology. It's okay. That doesn't mean the medications don't work. The medications are wonderful. It doesn't mean the surgery doesn't work. The surgery is wonderful. It just means that we don't get to ignore biology here. And so if we're not giving people realistic expectations about the biology of these procedures, the biology of obesity, and what we need to do, then it's not fair. We're not preparing people. Failure narrative has never helped.
Yeah.
Just try harder has never helped here. Like the whole diet industry has worked on that for 30, 40, 50 years. And a lot of people got rich from it, but it's not actually helped that many people. Just try harder. It's all your fault. Shame and blame doesn't get us any.
Yeah, 100%.
Real tools and agency work. Real tools, real information. That works. That's motivating me. Real results, sensible goals, meeting those goals and moving on. That helps. And I don't think it helps me. And I may lose patients because I make realistic expectations and deliver realistic expectations and say, look, this is what I really think about your weight goal. And this is what I think is the scientific likelihood that you will get there. And people might not like to hear that. And they may not choose to have me as a doctor. And that's okay. But I don't think I do anyone any good by sugarcoating and over promising. I think I do people a lot more good by us sitting down, looking at making sensible goals and then setting out to achieve them together, and then being ready to pivot and adjust down the track if they need more treatment for this or that.
Yeah. I had someone say to me once that, and I know it was true for me, that I was putting my self-worth into the hands of other people to look after.
Yeah.
And no one's going to look after something of mine as well as what I can look after it. And, it was when I sort of actually had that light bulb moment and realized I was always looking for the affirmations and from anywhere else. And I think whenever I was, trying to lose weight or whatever, if I wasn't getting that feedback, I thought I was failing. And so, I remember one of my attempts, I was going to the gym and I'd lost 6 kilos, but, I'd gone from sort of lifting 20 kilos to 40 and, all this other stuff. And the trainer was just like, yeah, now we just have to get the weight off here, and it wasn't good enough. And I think that's true for so many of us, that it didn't matter what we did, it wasn't good enough. So now we're having surgery. And I think a lot of us look at it and go, well, this is our last chance. And if this doesn't work, then what have I got?
See you later, man.
Stop.